Choosing Wisely Canada is a national campaign aimed at reducing unnecessary tests and treatments in healthcare. In this video, we present one of the top 5 dermatology recommendations for physicians and patients, which are set by the Canadian Dermatology Association and Choosing Wisely Canada. Don't routinely prescribe topical combination corticosteroid antifungal products. We will begin with a case. You are on your family medicine rotation. Jalen is a 32-year-old male who presents to the clinic with 1 week history of a new itchy rash over his left anterior thigh. He is otherwise healthy and is not on any medications. On examination, you note several oval-shaped brown to violaceous thin plaques on his left thigh with some scaling. Do you think this is a fungal infection or simply dermatitis? And what treatment should be prescribed? Dermatitis, commonly known as eczema, is the umbrella term for a group of acute or chronic itchy inflammatory skin conditions with eczematous reaction pattern. They are characterized by scaling, crusting, or serous oozing, and often treated with topical corticosteroids. The term dermatitis is often preceded by a qualifier to describe the type of dermatitis that is present. There are different types of dermatitis, and each has classic features. Atopic dermatitis is common in children and can be exacerbated by environmental triggers. The rash involves the extensor surfaces and cheeks or scalp for infants and young children, but has flexural distribution in older children and adults. In patients with darker skin, you may notice papular follicular changes, which are small bumps around hair follicles. Allergic contact dermatitis is a delayed type hypersensitivity reaction with onset of hours to days after allergen exposure. Sharp demarcation or distribution of rash, intense pruritus, and history of sensitization are clues to this diagnosis. Irritant contact dermatitis presents with eczematous lesions confined to the site of irritant exposure. It is due to physical barrier microtrauma, therefore will present with more rapid symptom onset than ACD. Seborrheic dermatitis is a common relapsing skin condition that occurs in seborrheic areas such as the scalp, central face, and anterior chest. Look for erythematous or salmon pink papules or plaques with yellow and greasy scales in seborrheic areas. Nummular dermatitis presents as round, oval, coin-shaped, erythematous and scaly papules or plaques with intense pruritus. Lesions are uniform, well demarcated, and usually asymmetric. Asteatotic dermatitis is from dry skin due to water loss from the stratum corneum, which is common in older patients. It occurs in the shins and lower legs with a cracked riverbed appearance. Stasis dermatitis occurs in the lower extremity secondary to chronic venous insufficiency. The various clinical presentations of dermatitis can overlap with other skin conditions, one being fungal infections caused by dermatophyte. It is important to differentiate them clinically because fungal infections are treated with topical antifungals and can be worsened by topical corticosteroids. Tinea presents as annular, scaly, and pruritic plaques with central clearing and a slightly raised and reddened leading edge. These are the major clinical subtypes of dermatophyte infections. If you can't clinically differentiate between a fungal infection and dermatitis, can we just prescribe a topical combination corticosteroid and antifungal product to treat both? Topical corticosteroid antifungal combination products, such as Lotriderm, typically contain high-potency corticosteroids. High-potency corticosteroids are inappropriate for application to the face and skin folds, as long-term use can lead to skin atrophy, telangiectasia, and striae. Studies have shown combination corticosteroid antifungal therapy has inferior clinical efficacy in treating cutaneous fungal infections due to steroid suppression effect on the antifungal. There are also higher reoccurrence rates due to partial treatment. Topical steroids can change the appearance and morphology of fungal infection, which can lead to misdiagnosis and delayed treatment. Clinical complications of topical steroid use on dermatophyte infection include the lesion extending beyond the primary lesion, also known as tinea incognito, or deeper into the hair follicles. The latter requires oral antifungal treatment, which could otherwise have been avoided. When it is clinically challenging to differentiate dermatitis from a fungal infection, a skin scraping is indicated and can guide the ultimate treatment. Getting the right sampling site is crucial. To obtain a sample, scrape the active margin of the lesion with a scalpel blade or edge of a glass slide using tangential force. Then, place 2 drops of 20% potassium hydroxide on the scrapings and cover with a cover slip. KOH will dissolve skin cells but leave fungal elements intact. If the sample is positive for a fungal infection, expect the presence of refractile, branching, and septate hyphal filaments under microscopy. False negatives can occur with inadequate sampling on the slide, and the sample can be stored in a fungal kit and be sent to the lab for microscopy and culture. Once a skin scraping confirms a dermatophyte infection, treatment will depend on the type, location, surface area of the infection, as well as patient age, degree of inflammation, and any comorbidities. Starting off with non-pharmacological therapies, advise your patient to wear loose-fitting clothes made from cotton or synthetic material to wick moisture from the skin surface. First-line pharmacological treatments include topical antifungals. Topical azoles are mainstay of treatment due to their broad-spectrum coverage against dermatophytes, yeasts, and molds. A meta-analysis found no statistically significant differences among 14 antifungals regarding outcome of mycologic cure at the end of treatment. However, terbinafine and butinafine were superior to clotrimazole for sustained cure. The different antifungals vary on number of applications per day or treatment duration. Although combined corticosteroid antifungal products should not be routinely prescribed for fungal infections, there are exceptions to this rule. Topical antifungals may be used in combination with mild potency topical steroids if there is severe inflammation or itch with the tinea infection. However, it should only be used short-term, 1 to 2 weeks, to control symptoms and provide itch relief. Combined therapy can also help reduce the spread of infection. A potential downside to using combined therapy is the risk of tinea incognito and Meiocchi granuloma, as mentioned earlier. Systemic antifungals may be indicated for tinea capitis, onychomycosis, tinea involving more than one body site, Meiocchi's granuloma, or for extensive cutaneous disease. If the skin scraping rules out fungal infection and you are confident with a diagnosis of dermatitis, topical corticosteroids are the treatment of choice. They have anti-inflammatory properties and cause cutaneous vasoconstriction, which help with pruritus and reduces inflammation. The choice of specific topical corticosteroids depend on the condition, severity of disease, location of lesion, and duration of treatment. The U.S. classification system for topical corticosteroids grades topical corticosteroids based on potency, with Class 1 being super high potency and Class 7 being least potent. Here is a simplified classification featuring common, mild, moderate, potent, and super potent corticosteroids. Super potent and potent topical corticosteroids are generally reserved for severe dermatoses, not including the face or intertriginous areas. They are useful for the palms and soles because of the thick stratum corneum, and the duration should not exceed 4 weeks. Moderate strength corticosteroids are excellent for mild to moderate dermatoses over the trunk and extremities. Treatment should be limited to 6 to 8 weeks. For the face, folds, and genital regions with thin skin, mild steroids are appropriate as higher potency corticosteroids are more likely to cause adverse events. In general, treatment effects should be reassessed timely and transitioned to non-steroidal topical agents if long-term treatment is needed. You also need to pick the right vehicles and formulations. Ointments are the most potent formulation due to its occlusive property. It tends to be thick, sticky, and greasy, and less cosmetically pleasing. Creams are less potent than ointments, but more potent than lotions. Lotions are useful in hairy areas or large surface areas, but it can dry out the skin. Lastly, foams are an excellent choice for hairy regions like the scalp, but they can be more expensive. Choosing the correct strength of corticosteroids with the correct formulation is the key to successfully treat dermatitis and minimize adverse effects. Going back to the case, the annular plaques on Jalen's thighs are well demarcated and scaly with intense pruritus. You do not appreciate any leading borders. All characteristics point towards a diagnosis of nummular dermatitis rather than tinea. A negative skin scraping confirms your diagnosis. Given the location of the rash, you write him the prescription of betamethasone valerate 0.1% cream to be applied to the affected area topically, BID for 2 weeks with no refills. You also discuss the lifestyle modifications of avoiding hot showers and applying unscented thick moisturizer twice a day. You book him for a follow-up appointment in 2 weeks. From this video, we hope you understand the CWC's recommendation of don't routinely prescribe topical combination corticosteroid antifungal products. The take-home messages of this video are: a skin scraping can differentiate a fungal infection from dermatitis if the clinical presentation is ambiguous. Do not routinely prescribe topical combination corticosteroid antifungal products for fungal infections unless the patient is complaining of intense itch or if there is severe inflammation. When topical combination corticosteroid antifungal products are indicated, use a short course of low-medium potency corticosteroids and change to antifungal monotherapy after 1 to 2 weeks. The key to successfully treating dermatitis is to pick topical corticosteroids with the right strength and vehicle while considering the severity, body location, size of dermatitis, and patient preference.